Welcome back to Alterations of Renal and Urinary Function. Let's move on here and talk a little bit about renal failure. And first of all, we're going to start off with acute renal failure before we look at chronic renal failure. Now, acute renal failure can be of one of three different causes. It can be pre-renal, it can be intrarenal, or post-renal. As the diagram here is illustrating, pre-renal means that the problem is with the circulation. There's not enough blood flow getting to the kidney in order to perfuse the kidney. So pre-renal is not enough blood flow getting to the kidney. Intrarenal means that there's a problem with the kidney itself. Typically, what this would involve is that we've got some kind of dysfunction to the filtration mechanism of the kidney itself. So maybe there's been damage that has occurred directly to the nephron, and that's what's causing the patient to have intrarenal type of failure. The third type is called postrenal failure. In this situation, we have blockage of our urinary tract. Urine is backing up into the kidneys and causing too much pressure in the kidneys, which then causes the patient to have postrenal type failure. Now, we just talked about that with urinary tract obstructions and with stones, that they can block the urinary tract. Urine backs up into the kidney and causes too much pressure on the kidney, and then we get renal failure. Now, that's called postrenal type of renal failure. A little bit more detail here. Pre-renal failure. What happens is that from one of these variety of different causes, so maybe the patient has hypovolemia, or the patient has a hemorrhage, which would cause hypovolemia, and hypotension. Now, the hypotension could be from hypovolemia, so it could be hypovolemic shock, it could be cardiogenic shock, it could be septic shock, anything that's causing a low blood pressure to the kidney, not enough blood flow to the kidney, can cause the patient to develop pre-renal type failure. So our GFR is going to decrease because of a decrease in our filtration pressure, because there's less blood flow getting to the kidney. What we're going to see as far as our symptoms goes is an increase in our BUN and creatinine. Those are going to start to rise over a period of a couple days here. Oliguria, so decrease in our urine output. There's not enough blood flow getting to the kidney, so therefore there's not going to be enough filtration and enough urine being produced. Intrarenal, unfortunately, is the more severe type of acute renal failure, because we're actually damaging the filtration mechanism. It's like burning holes in your coffee filter. We're damaging the filter itself. So we can have renal ischemia cause this, pyelonephritis, nephrotoxins. Here's a very common cause for intrarenal type of failure. Some kind of nephrotoxin. Many of our drugs are nephrotoxic. Also, we can have infection. And acute tubular necrosis is one of the most common causes of having intrarenal type failure. Acute tubular necrosis, as the name implies, means we have necrosis of the tubules of the capsule of the kidney, and that's what's causing the patient to have intrarenal failure. ATN can be caused by infection, it can be caused by ischemia, and a lot of other conditions. Postrenal means we have obstruction of our urine flow. Urine is backing up into the kidney, and that's what's causing the patient to have damage to the kidney and to have renal failure. So we talked about that in relationship to our stones, in relationship to our obstructions, and how urine is going to back up into the kidney. Then we have too much pressure in the kidney that causes damage to the kidney, and then the patient ends up having these long-term consequences. So what leads to a patient developing oliguria as a result of having injury to the kidney? And that's what this diagram here is helping to illustrate. Look at the top. We either have ischemia or a nephrotoxin causing damage to the kidney. Let's go down the left-hand side first, then we'll come back over to the right. Possible glomerular injury occurs, which causes decreased permeability and decreased surface area for filtration to occur, and then a decreased GFR. Going down the middle, we have intrarenal vasoconstriction. Because there's not enough blood flow getting to the kidney responds to that by saying, hey, we need to increase perfusion pressure. The kidney doesn't know how to respond. All it knows is it's trying to maintain perfusion pressure, so it causes vasoconstriction, further limiting blood flow to the kidney, and that causes a further decrease in GFR. On the right, tubular injury, for example, acute tubular necrosis, can cause cellular cast formation, which can then cause, and cellular cast, that's just like, it's like waste products of breakdown of cells in the renal system that is causing, and these cells kind of clump together, and that's what's causing the obstruction, which increases our intraluminal pressure, decreasing our GFR. Also, tubular injury can cause a tubular back leak, which then can also contribute to oliguria. So decreased GFR, tubular back leak, causing the patient to develop oliguria, which is decreased urine output, less than 100 milliliters per day. Signs or stages of acute renal failure. So acute renal failure don't just get renal failure and then the patient gets recovered and they're fine. What happens is it goes through these phases. The first phase of which is going to be called the oliguric phase. And during the oliguric phase, we're going to see, and this lasts usually from a day to maybe a couple weeks, depends on the severity of the ischemia, the injury, or the obstruction. But the oliguric phase is going to look just like renal failure. We're going to see decreased urine output. We're going to see an increase in BUN and creatinine. Going to look just like the patient has renal failure. However, keep in mind that acute renal failure is a sudden cessation of renal function, so it happens quickly, and the patient does not have time to get used to it. Next, we move into the diuretic phase. In this phase, what's happening is the kidneys are just kind of opening up and letting stuff fall through. Not really filtering, just kind of opening up and letting stuff fall through. The patient's going to develop a large amount of urine output. So we went from oliguria to a large amount of urine output. Now this looks good. Okay, urine output's starting to pick back up again. You might be thinking, hey, this is a great sign here. We're looking good. But the problem is that we're not filtering. So it's just letting stuff dump through. We're not filtering. So we still don't have good filtration occurring. Then finally we'll go into the recovery phase. The recovery phase may take from weeks to months before the GFR returns to normal. So what this diagram here is illustrating is it's illustrating what happens with the BUN and creatinine during these different stages. We have that initiating stage, the oliguric stage, when the BUN and creatinine rises sharply. Then we start to go into the diuretic phase where we dump off some of our BUN and creatinine, but you notice BUN and creatinine don't come back to normal. And then we go into recovery, which takes from weeks to months for the BUN and creatinine to finally fall back down into the normal range. On the other hand, chronic renal failure is an irreversible loss of renal function. So we don't go into the diuretic and recovery phases here. This is just oliguric. We have a loss of renal or nephron mass. Now, to understand that we have a lot of redundancy in our renal function. That's why people can donate a kidney to somebody else. We don't need all that renal function, but we have a lot of redundancy in our renal function because if something happens and we lose all of our renal function, then we're going to end up having renal failure. So there's a lot of redundancy here. We have to lose a lot of our renal function in order to get here. As we're starting to lose renal function, the remaining nephrons will hypertrophy in order to maintain a normal urine output. Uremia, or the increase in the amount of blood urea nitrogen, or BUN, in the blood, is going to cause a number of different adverse effects on our patient. Now, my little increases and decreases here didn't work so well. They came out as being boxes. So you can fill into the box an arrow going up or down as we go through. The first stage of chronic renal failure is decreased renal reserve. What's happening is at this point in time we have a decrease in the number of functioning nephrons. But there's no symptoms. We don't have an increase in our BUN and creatinine. We're not seeing anything at all at this point in time other than just a decrease in our number of functional nephrons. Now, we may pick this up if we bring the patient to the hospital and we do a GFR, glomerular filtration rate. We may be able to pick this up. Renal insufficiency. Now we're having a asymptomatic increase in BUN and creatinine. So the BUN and creatinine are increasing, but it's still asymptomatic. The patient doesn't know they have a problem. They come into the hospital. You say, hey, you ever have any kidney problems? Nah, kidneys are fine. They don't know they got a problem with the kidneys. Next, we move into renal failure. Now we're having a symptomatic increase in BUN and creatinine. So a symptomatic increase in BUN and creatinine, and that's what we call renal failure. Now, these patients, though, in renal failure don't necessarily need to have dialysis. This patient may simply just have this increase in BUN and creatinine that they can manage with their diet and with exercise, etc., except when they become ill. Now, when they become ill and come into the hospital, they may need to have dialysis just to control it while they're sick. Lastly, We have end-stage renal disease. This is the patient who has a severe increase in BUN and creatinine. Chronic dialysis is going to be needed for this patient because of the chronic high amount of uremia that we have in the bloodstream. Okay, so uremia. This is that high BUN. So when you go in and you take a look at somebody's labs and you see, wow, they've got this high BUN. Well, uremia, this protein, this product of protein metabolism that builds up in the blood, this uremia. Urea is very irritating to all the tissues in the body, and it's going to cause a lot of different symptoms in our patient. Stuff like infection, itching, the nausea, the vomiting, the anorexia, neurologic changes as far as having peripheral neuromuscular irritability and even central neuromuscular irritability. In addition, we can also see some additional signs like bone demineralization. Okay, that can occur as a result of having renal failure. We can't regulate our phosphorus. Calcium starts leaving the bones. We end up with a high calcium level because the calcium is leaking into or it's leaving the bones, but it is also being excreted by, or it's not being absorbed because we're not synthesizing vitamin D and being excreted. Acidosis can occur. Remember, the kidneys are not being able to excrete out the hydrogen ions, so acidosis starts to occur. We can get hypertension because of the increase in the amount of fluid that's on board, the edema formation. The patient may develop stroke or heart failure, pericarditis, pulmonary edema. Lots of signs and symptoms, lots of complications of chronic renal failure. This picture here is showing a lot of the different types of symptoms we may see in a patient who has chronic renal failure. So just looking all around there, you can see that obviously this affects a large part of the body. And just a couple of these: lethargy, seizures, coma. Okay, that's the central nervous system being affected by that high urea nitrogen level in the bloodstream. Anorexia, nausea, vomiting. This urea in the bloodstream is also causing irritation to the GI tract, and that's where we're seeing the anorexia, nausea, and vomiting coming from. The hypertension, pericarditis, and heart failure all coming because the patient is retaining too much fluid. They can't excrete the fluid out. We can have problems with their breathing as well, nail changes and bone pain. Remember, we're demineralizing the bone. We can have problems with muscle weakness, and peripheral neuropathy also occurring because of that high urea nitrogen level in the bloodstream. So you can see there's a lot of different situations, a lot of different problems occurring here, and most of them are going to be the direct result of having a high urea nitrogen level in the blood. Therefore, if we dialyze the patient and we can remove some of this stuff from their body, the patient obviously is probably going to feel a lot better, and they're not going to have as many of these systemic symptoms. What this diagram here is showing is how we get some of the symptoms that are related to a patient having renal dysfunction. So we have an injury to the kidney occurring, a loss of nephrons. We're going to have an increase in our angiotensin II, and that's going to cause a variety of different problems, increasing our glomerular capillary hypertension. That's going to be one of the causes or one of the problems. Glomerular permeability and filtration increases, proteinuria, so we start to dump protein. We start to have an increase in our tubular protein reabsorption and tubulointerstitial inflammation and fibrosis and scarring of the kidney. That'll also contribute to our systemic hypertension along with angiotensin being released. So those two things combined are going to continue to add to hypertension that we see in our patients who have renal dysfunction. There's another renal problem that we may encounter, and certainly as you learn more about your medications, you're going to start to learn more about how drugs can cause problems with the kidneys. Understand that most medications that we take are probably going to be detoxified by the liver and are going to be excreted by the kidneys. So most of the drugs we take are going to touch the kidney in some way, and that can cause the patient to end up having some severe problems with their renal function, and we call this nephrotoxicity. Now, it doesn't just have to be drugs, it can also be other kinds of poisons that cause damage to the kidney. Understand that the kidney can be affected in 3 different manners from having drug-induced nephrotoxicity. So let's take a look at those. First of all, it could be prerenal, which means we don't have enough blood flow coming to the kidney. And that's caused by the drug. So the drug is causing the patient not to have enough blood flow coming to the kidney. So our drug is going to decrease blood flow to the kidney. Our prompt action here for this patient would be to discontinue the medication. What it's saying here under presentation is we could expect to see oliguria occurring in the patient. We could expect to see a decrease in our FeNA. Now, FeNA is the fraction of excreted sodium. Fraction of excreted sodium. Most of the time this will be measured in our patients by checking a urine sodium. So instead of looking for a fraction of excreted sodium, we're going to see a urine sodium that is elevated. Our urine osmolality, remember again, whenever you hear the term osmolality, think concentration. So our urine concentration will be high. That makes sense with having oliguria. The next type is intrinsic or intrarenal type of nephrotic injury that can occur from our medication. What's happening is the drug itself is burning holes in the filter. So the drug itself is causing damage to the nephron. This is the, again, most severe type because we're damaging the filter. So it's going to be really hard to recover from that. When the filter gets damaged, the filter is going to repair by putting scar tissue in the place. And in place of having normal healthy filtration tissue, now we have scar tissue, and that doesn't work very well. Although there are many, many different drugs that can cause the patient to have an intrinsic type of nephrotoxicity, we think of these in terms of the internus quartet. So these are the four most common types of medications that can cause damage to a patient's kidneys. Those are going to be radiocontrast dye. So this happens over in the x-ray department. They're going to send the patient for a CT scan, and they put radio contrast dye in to help light up some of the organs so that we can better see what stuff is there. Unfortunately, that dye also has to go through the kidneys and be excreted, and that can cause damage to the kidneys on its way out. A medication called aminoglycosides, these are antibiotics, gentamicin being one of them in this class. Aminoglycosides are also nephrotoxic drugs. They're going to burn holes in that kidney and cause damage to the kidney. NSAIDs, non-steroidal anti-inflammatories, this is your Motrin, your Advil, stuff like that. And then we have our ACE inhibitors, angiotensin-converting enzyme inhibitors. These are medications that are used to control blood pressure. Symptom-wise, we'd expect a normal type of urine volume initially because we're burning holes in the filter. We're burning holes in the filter. Again, think of this as like being a coffee filter. And if we burn holes in the coffee filter, coffee is going to continue to flow through. As a matter of fact, it's probably going to flow through even better than it did before. So we'll have a normal volume initially, but eventually oliguria is going to ensue because the body's going to start to heal up that filter. And it's like taking duct tape and putting it on that coffee filter. What is that going to be like when you're done? It's not going to filter very well, and oliguria will then ensue. We'll see an increase in our FeNA, that's our sodium, or urine sodium, and an increase in eosinophils. So treatment would be to discontinue the drug. Now, the best thing we can do to try to prevent nephrotoxicity in our patients is to give them lots of fluid. So here it's saying normal saline at 150 milliliters an hour. Obviously, we can give the patient fluid by mouth if that's appropriate, but we want to give the patient lots and lots of fluids so that we're running lots and lots of fluids to the kidney so that this drug does not have enough time to take hold and to cause damage. Plasmapheresis might also be used for patients who have certain kinds of immunogenic attacks on their kidneys. The third type, or the last type of nephrotoxicity, is called obstructive. And just like having a stone, a renal stone occurring in your patient, in this case what we're having is we're having the obstruction of the urinary tract caused by a precipitation of the drug in the urinary tract. So let's say, for example, your patient is taking a cyclovir. That is a medication that's an antiviral, and that medication then gets cleared through the liver, comes down to the kidney. The kidney's about to dump it off, but as the drug is getting cleared, it crystallizes, turns into little crystals, and those little crystals form into bigger crystals, and they form into a rock, and that rock, that stone, gets stuck in the urinary tract, and it causes damage just like any other kind of stone would. The best way to prevent this again is by giving the patient lots of volume. So we're running all that fluid through and hopefully not causing a lot of problems. Second thing is that an acidic urine tends to cause these drugs to crystallize more often than an alkalytic urine. So we would want the urine to be more alkaline rather than to be more acidic. You're going to learn more about this with nutrition when you learn about how to change the patient's urine acid or alkaline basis depending upon the food they're taking. But in general, fruits and vegetables cause more of an alkaline urine as opposed to eating a lot of meats and proteins, which cause more of an acidic type of a urine. Okay, let's take a look at some more questions here. Nephrotic syndrome is associated with blank to plasma blank. And as you said D, you're correct, increased glomerular permeability and to proteins. Which of the following is not a symptom of chronic renal failure? And if you said hypercalcemia, you were correct. So we end up having a low calcium level rather than a high calcium level occurring in the patient who has renal failure. Remember that what happens is that the calcium level becomes low and the phosphorus level is the one that becomes high. Which symptoms describe a person in renal failure? Now select all of these that apply. Okay, now if you said an elevated serum creatinine and oliguria, you'd be correct. Leukocytosis does not necessarily occur in patients who have renal dysfunction, and definitely not a low BUN. Instead, what we would see is a high BUN in our patients who have renal dysfunction. Well, I want to thank you for joining me for alterations in renal and urinary function. My name is David Woodruff. Hey, until next time, bye now.